I have to change it because it doesn't
Yeah,
have my name.
that's fine. Oh, is it inverted? That's fine. Okay, so can we do
It also corrected my name to John.
That's as best as I'm going to get.
So it's so easy, it's all updated in 1 second. Yeah, because just also my place. Because I was convinced that it was and there was, and then just updated it.
Try the exact same thing you just did, but with this. You make an event. I think just. I don't think just don't delete it now. Just remake it.
It's getting to a stage. It's getting really good. Shall I tell you? I am. It's busy. The same thing with George. If your mother's a person like where are you based? Sophie? How is it? Yeah, it's good. You've got taskmaster. Oh, really? Oh, wait.
But that should be fine.
When it's signed into I was thinking of you today. Then you have let you down.
I might need to switch this off. I can't delete this.
I think it might be worth just making it actual.
This is it. That's all we're going to get. I think
Yeah, about 5
I am doing all my hours. So come down to Hi.
You're on the live stream.
Yeah. So you
Yeah, I was trying to friggin' like double topper.
Possible to leave these two seats free just because your voices will just be going to that and that's the live stream, so you might not be able to hear the speakers at all. Is that fair? Sorry about that.
What's going on here? How do I add?
Thank you.
That one? That way better. So just make sure it's like that. Okay? Or you can put it like that. Yeah, then you yeah. So I used to work with deaf mental health services at
So I think we're just about to start. Thank you all for coming, especially on Bake Off evening. Quick escape. But thank you to our speakers tonight for talking to us about their career in paediatric psychiatry. So over to you to introduce yourself and speakers. Thank you very much.
Thank you. God, we're both amazed at the interest.
the
The keenness. God, third-year medical students is fantastic. You completely changed our attitude now of medical students. As a third-year medical student, what did I do? Yes, I did go on to the wards in the evening. I was an absolute, what do you call it?
Latha was a real swot.
I was a swot, but I didn't expect all of it. So it's good to have you here. I'm Dr Hackett. I'm a consultant child and adult psychiatrist. I'm based at the Winnicott Centre, which is a part of Manchester Foundation Trust Hospitals.
And I'm Nilo Aslam. I'm a consultant child and adolescent psychiatrist. I work with Latha. And I initially trained as a paediatrician and then changed to psychiatry, so I did a bit of both. And I took over from Latha as the training programme director for the higher specialist training in the northwest. We've got another TPD for Mersey.
Okay. I mean, I've just put together a talk thinking this is what I'd like to tell you all about my specialty, because I want all of you to do my specialty. Okay? So that's what I'm trying to do, is to sell it to you, and I hope I sell it well. If not, I'm not doing my job. The other thing is, I keep telling everybody, I was 64 last month, was it? Yeah, last month. And I'm still working. So I hope that I sort of try and persuade you to do the same, that the sort of specialties we work in, if you keep your interests up, and you can carry on doing it. Okay? So what I've done is, I've actually told you how to become a consultant child and adult psychiatrist first, and also to give you a sort of flavour of what I do as a consultant psychiatrist. And Nilo is going, another job Nilo does is she's also the child and adult psychiatrist as a liaison, a psychiatrist for Royal Manchester Children's Hospital. And Ellie sort of wanted us to think about I wanted sort of to know what we as a team did to support following the Manchester bomb. So Neela's going to
So I'll talk to you about our risk
that as well.
management,
Okay.
some of the things that we learned from that. So Latha, you're going to
Yeah.
do the bulk of the talking
Yes,
about
I'll try and do
about the facts.
Yeah, the boring bits, okay? So, first of course, most of the time people ask us, you may not ask this, what is your training, what do you need to do? One is you've got to be a doctor, then you have to do your 2-year foundation year training, then you have to do 3-year core training in psychiatry. When you do core training in psychiatry, if you've done training placements, you might have come across core trainees in psychiatry. They used to be called SHOs and registrars before, now they're called core training. They do 6 jobs, 6 months each. And during that time, they take the Royal College of Psychiatrists exams as well. And at present, there's a paper A, paper B, and there is the clinical one, which is a CASC. And paper A, now, from last year onwards, you can do it in your foundation year 2. Before they were not allowed, you only allowed in core training, but now you're allowed to do that. The other thing is when you go to higher specialist training, you have national interviews like the way you have for core training, and you get into ST4 training, and that is for 3 years. And those placements are sort of 1 year at a time in different specialties so that you can gain all your competency before you take up your consultant. What we also like is if people have done sort of pediatrics, it's quite desirable, but not essential. So when Nilo came on to the scheme, I was the training program director who sort of appointed her. So fantastic. We do have a number of people who have interest in pediatrics, done some pediatrics, and then decided to child and adult psychiatry, which is really good. But now, from this year onwards, the Royal College of Psychiatrists have put together what is called the run-through training pilot for camps. So they can start at, you're having a great time in the background. So we are used to working with children, so we're all right. They fell down, I don't know what they did. Having a party at the back, yeah. So camps run-through training is, you can start at, you have a national interview for core training, and you go through, you don't have to have a sort of interviews for ST4, so you get the whole 6-year job right to the beginning. You still have to have your competency, you still have to have your exams to go to ST4, but you don't have to have an interview. We also have things like academic clinical fellow posts, which are sort of academic posts you have a sort of, in Manchester especially, only in certain parts of the country do we have academic clinical fellows in psychiatry. Manchester is one of them. I think there's in London, Oxford, I'm not sure whether Cambridge has, even though they are sort of pretty big sort of academic departments. But Manchester does have a very good psychiatry academic department, so that's why we got these posts. So if you want to go take a career, sort of train as an academic psychiatrist, Manchester is one of the places to be, and there are lots of these jobs. You should consider that if you're interested in academic. And I have spoken to some of you guys who come to see me about this. Okay? As a consultant child and adult psychiatrist, it's varied. We can do varied jobs. For example, when I was a consultant psychiatrist, I had done lots of research before I went into to my consultant job, funded by a Wellcome Fellowship. Had a great time abroad doing research for 2 years in a place where I had grown up, so I had 2 years of fun, but it was a big project we had to do. Came back, went into a district community post, and then I had just had my basic training in, what do you call it, as a senior registrar those days. And then I had to develop my special interests. Okay, my special interest was in learning disability and autism, and that's what I had done for the last 25 years in child and adult psychiatry. So you may be appointed as a district community, in the district community team, as a consultant child and adult psychiatrist, but you can develop your special interest and make that your lifetime work. And that's what I've done. And because of that, I'm also now involved with sort of NIHR supported grants for research, because you need to have that sort of experience to get certain sort of grants to do certain research. So you can do these things as a consultant, depending on what your interests are. The other thing is pediatric liaison. Milo's doing that. You can work as a consultant in 16 to 18 service, or you can work part-time in that and part-time in the district. There are you can do work in early intervention, psychosis team. You can be a neurodevelopmental disorders. There are some specific posts. For example, in Greater Manchester, there are quite a few posts where there are child and adult psychiatrists only doing neurodevelopmental disorder posts. You can have special interest working with children who are looked after because they have complex difficulties. You can be a forensic child and adult psychiatrist, which is sort of a job for us in the Northwest. We are very lucky to have the Gardner unit and the outpatient, which is called, I think it's called FCAMS now, which is for, and they cover a big area, and they they provide consultation and liaison for a big area of community child and adult psychiatrists. We have inpatient services, you can be a consultant there. And also academic child and adult psychiatry. In Manchester we have two academics. One is Professor Jonathan Green, the other is, he's a senior lecturer, Shruti Garg, who's got a who was a trainee with us. She was a higher specialist trainee with us. And on the child and adult psychiatry higher specialist scheme, we encourage them to do research. All have to do research to get their research competency. And Shruti was one of these guys who had never done any research and got interested in research. She got a grant from the Biomedical Research Council as a trainee with us. And now she's got John Hopkins Fellowship from the US. And these are trainees we trained in Manchester.
She's the first person outside the US to get that particular fellowship.
Yeah. Yeah. So you can do these things, and these are people who have done no research at all, come onto our scheme, got hooked onto the research interest, and then carried on. And I think she will be, highly likely she'll be our next professor in Manchester. Okay. So what do we do as a service? We see children and young people from the age of 2 to 18 of any ability. That's what we do in Manchester, and that's what most child and adult psychiatry CAMS team do. The reason I'm talking about any abilities, you'll come across some teams who will say we don't see children with learning disability. We only see children who do not have learning disability. One is we've never done that. Two is it's a fallacy, because most of the time we do not know whether they've got learning disability or not. So how do you judge? Okay? To judge learning disability, you have to do a formal testing. Most of these children wouldn't have. So it's an absolute fallacy to say that. And in Manchester, it's always been the case that we see children of any ability, and now the push from the Department of Health is that's how we have to do. We also have in Manchester preschool camps who sees children under the age of 4. And in Manchester, it's mostly run by clinical psychology team. But there are other parts of the country, they do have psychiatry input as well. And we accept referrals from any professionals in health, education, social care, and now we also accept self-referrals. If parents are concerned, they can make a referral to our service. And we were worried when this was pushed by the government a few years ago, that we will be inundated by referrals from parents who are worried, but not children with no problems, but actually that hasn't been the case at all. And it's been quite sensible referrals to our service. In our service, we have we are an MDT, and we also have a multi-agency team. The MDT consists of child and adult psychiatrists, clinical psychologists. We have child mental health practitioners. These are practitioners of different backgrounds. They could be social workers, they could be nurses, they could be OTs, but the term we use in child psychiatry is CMHP. For example, in general adult psychiatry, they would be called occupational therapists, they would be called nurses, they would be called something else, social workers, but this term is used for, and we have lots of people with lots of different backgrounds. We also have family therapists, we have child and adolescent psychotherapists, and we have specialist teams. That's where the multi-agency comes. For example, for us, in Manchester, we have a specialist team for assessment of children with autism or social communication difficulties, and we have speech and language therapists and education psychologists as a part of our team. We also have specialist team for looked after children. Again, it's a multi-agency team. Okay? The sort of disorders, the sort of problems we see, what I sort of put in inverted commas, is behavior, sort of generic term as behavior problems. I don't believe that children do want to behave badly. Children behave differently because they can't make sense of the world. There's something that's happening, they can't make sense. So we may get a referral saying a child has got behavior problem. It can turn out to be anything. Okay? It can turn out to be anything. The child might have a diagnosable condition like attention deficit hyperactive disorder, ADHD. He might have autism spectrum disorder. He might be low in mood. He might be anxious. He might be phobic. He might have other problems like he might be having quite significant learning disability nobody's picked up. So 10-year-old behaving like a 3-year-old, and 3-year-old, what they do is they have temper tantrums, they do this, they do various other things. But if your cognitive ability is that of a 3-year-old, you're behaving like a 3-year-old, not like a 10-year-old. But the referral might be, he's got behavior problems, can you sort him out, sort of thing. Okay? So these are sort of variety of things we see. Okay? And we provide sort of quite a lot of psychological interventions, and I've sort of put the range of it. And if you guys have come across a sort of worked in psychiatry, or I don't know how many of you would have done psychiatry if you do in 3rd year? 4th year, isn't it? Mind and movement. We call it mind and dance, really. A sort of module of you. Yeah, and so this is the interventions we provide. Quite a lot of the psychological intervention, but we also provide medical interventions. We provide medicine for some of these conditions. Okay? I just thought I'll just give you a flavor of the sort of things we see. 8-year-old presenting with significant behavior problems both at home and at school. And this has been evident since he was a toddler, about 18 months. Okay? So we would assess him, and during the assessment we would take detailed information from parents or carers. We'll take detailed information from school. We'll observe the child in the clinic as well as school. And we'll also look at his learning. Okay? And then we'll also look at other things. When a child walks in, you see, has the child got anything else wrong with him? Is he dysmorphic? What's he like in his motor development? Has he got other features which could be sort of pointer to what's happening? Then we'll formulate and then we'll diagnose. For example, Adam would have anything from sort of lots of problems because there are huge problems at home. A combination of school not understanding his needs. He might have significant learning difficulty that's not being picked up. He might have autism. Okay, and it's our job when we do when we get all this information to analyze it to see. He might have a genetic syndrome along with it. Okay, so this is what we do in our assessment: is take all this information and then synthesize it. And to synthesize this is a skill you develop during your training. And you do that as well as you go up sort of your undergrad, and when you become a foundation year, you will be using all this your information you've studied to synthesize. And that is what we do in our assessments. Now this is Colin, who's 11. He's a looked after child, lives with a carer, and this is his 3rd foster carer. And he was taken away from his mother at 3 years of age because she could not look after the children, and she had about 3 or 4 children, and he's one of them. Sister has a diagnosis of fetal alcohol syndrome, they told us, and she lives with another carer. And he's come to us for a second opinion. He's already got a diagnosis of ADHD. So when I saw Colin, I took again the assessment. When he walked in, the first thing that struck me was how small he was. He was 11-year-old, he looked like a 7-year-old. I looked at his face, I thought, he's got FAS, he's got fetal alcohol syndrome. Okay? But everywhere, in every letter you see is that he doesn't have FAS, he doesn't have, his sister's got it, he doesn't have. But when you look at him, you realize he's got it. But when you have this evidence in front of you from all the other professionals, you think, I think he's got FAS, so I need to do this, okay? So my assessment was to get all the information from everyone. And this child was known to CAMS from the age of 3. So there were 3 sets of notes in 3 different departments. And there was community pediatric notes, social services notes, medical dentist did know him, and the school, and I did my assessment both at clinic and school. What we found was, I don't think he's got ADHD, he's got autism spectrum disorder, he's got learning difficulty, he does have fast. It was diagnosed when he was 7, and the letter that was sent out hadn't reached the people they should have reached, really. And my intervention would be actually working with the system and working with school, getting them, because this child was hardly sitting in the classroom at all. He wasn't sitting in the class at all, he was out all the time, and getting them to understand why he's presenting the way, because they were all blaming his difficulties to be because of the dreadful time he had with his mother. And this is all about attachment. Attachment would contribute to his difficulties, but what was his main problem was because he's got his brain, when it was being wired, his mother was taking far too much alcohol, so the wiring didn't happen properly. So he had loads of problems in lots of fields, along with his learning, his language, his attention, and also he had social communication difficulties. So the intervention was working with a number of professionals and getting him, and he did. He's now 17 this fall, and he's done everything. Okay. Thomas was 13. He was referred to us when he was 13, and they asked me whether he had to ask a question, has he got ASD? And he already had a diagnosis of Cri du Chat, and he had severe learning difficulties and he was in a special school. And here the work was not just the assessment, because he was in a special school, it's in a fantastic special school. It wasn't the diagnosis, it was actually helping these parents with the diagnosis. We did provide medication for his sort of, terrible he never sat still at all, to make him manageable. We had to try sort of medication which we normally give for ADHD. But in this case, it was most of the work was actually working with the parents to understand the child's need, to support them in the care of this child, also support the parents to let go of this child to be cared by other people. Because there was no way these parents could have cared, because they had 2 other children as well, because of his difficult situation. So assessment, diagnosis, intervention differs depending on sort of what the problems are. Okay? So that's where I stop, and if you want to ask any questions with what I've said, please do.
So you know, all these children that came through, what is the main referral from them? Where does the referral come from?
Okay, all right. It's still, I think, is general practitioners. It's still, because you've got, you've got all these processes. So I think it's mainly still general practitioners. Next will be community feeds, and then the rest, everybody else, really. Okay?
And school.
And school,
What school will do is raise a concern and generally ask the school nurse to see, and then the school nurses will refer, they'll discuss it with the GP, because that's where they're based, and then they'll refer. So quite a lot come from, because the people, children don't turn up saying, I've got behavioural problems. It'll be other people who are bothered. So it'll either be school or parents. They're the people who will notice.
That is one of the essential difference, because one of the questions you asked, Ellie, was sort of, I think, discussing this, was that how is it different from general adult psychiatry? Okay, one is these are small people, and as Nilo just said, I want to mention that Nilo said, is that they don't come and say, I've got this problem, can you see me? It's somebody else bringing. Okay. The other thing that also brings about a challenge as well. The challenge could be everybody else thinks there's a problem with the child, parents don't think, and so they're not brought to the service on time. So that can happen as well.
Or the other way is that we have parents who are very concerned, and they raise concerns with the school, but the school aren't concerned. So we get differences of opinion, which is difficult. There are parents who are concerned. We had one the other week where they want an assessment, but they don't want the child involved, which isn't really possible and isn't appropriate. So they don't want the child to know that they're having this assessment, which you clinically can't do, but also isn't really appropriate for you to make a diagnosis and then say this child was 12, for them to not know about what's going on. You couldn't do it anyway, but having that conversation with people, we want to explore this, I want to, basically they want you to say that, oh, there's nothing wrong, but you just don't want to go down that route. So there are lots of different challenges to it.
There are. Really. Any other, yeah?
I got an opportunity to go to Turkey to see their interventions about schizophrenia and stuff like that, and it's more into adults, but one thing that really did strike me is how they could introduce VR into treating phobias. So we got a chance to see it. So I'm just asking, is there any evidence in the UK developing these sort of systems or these new machines that would actually help not only treat them but necessarily cure them?
To use what, sorry?
They use these specialists, they're all in Turkish, so I couldn't even reel them off to you, but they use these specialist machines, and with these adults, they get transferred over to this only accredited hospital in Europe to go and visit, and then they would have this massive rehab with OTs, physios, GPs, psychiatrists, and then they'd go in for about 6 weeks, and they'd have these really intense rehab machines, and then they'd actually come out a completely different person. So the question is the UK doing that way?
What actual machines?
So, like, one of them was they would
information.
sit and it would manipulate the brain using different coloured spots. And that's one of psychiatry. And then they would react in a certain way, and then that's how it formed their brain.
I would love to see the evidence for this, okay? I do read my journal still now, and I would find it fascinating. I don't think there's evidence for that yet.
I think, there's, and I'm sure all of you have heard of, ECT, because it gets a lot of bad press, electroconvulsive therapy, which has a very good evidence base, for treatment-resistant depression and for sort of catatonic schizophrenia. The other sort of things that have been explored are, transcranial stimulation, this magnetic stimulation or low current stimulation, with placing electrodes. But the idea that it manipulates your brain in a sort of very particular way, I would say is a false one. What you will find is that if they're having treatment success, which I'm sure they are if people are spending lots of money to send people there, it will be because of the OTs and the psychiatrists and the psychologists. That kind of intensive MDT intervention is what will be making a difference. The other thing to remember about psychiatric illness, and I think and any illness really, is that there are factors that are intrinsic to the patient, and then there are environmental factors. And with psychiatry, those environmental factors probably matter a lot more, and they are the demands of everyday life and the stresses of everyday life and everything that's going on in your environment. So it's a bit like when you go on holiday and you forget about your exams, you feel like a slightly different person, don't you? Well, some people do. But you're taken away, you're taken out of that. So we know with our patients, if you take them out of an environment, you put them in an inpatient environment where you're removing a lot of stress, the demands of education, the demands of work, family interactions, family dynamics, you remove all of that. Actually, what you're left with is intrinsic to the patient, and it's much easier to treat that. What's hard about treating patients, any patients, is treating them in their environment. It's like, say, somebody with respiratory disease. If you can take away their smoking, it makes your job a million times easier. But trying to treat someone's respiratory disease while they continue to smoke makes it much harder. Does that kind of make sense?
Yeah.
So I suspect it's not the machines that are making the big difference. It's the fact that
It's just very interesting because it's only them and another US hospital that are actually trying all these different interventions.
Yeah. What does that tell you?
Well, if they want to spend money in that domain.
I think the thing is that there are always, not, and this isn't to be dismissive, there are always novel treatments, and there's always, there are always people trying to push the boundaries of research. That's fine. But then when people are desperately ill I think desperate is the word. So if I was in a situation where I was really, really ill and whatever had been offered on the NHS or in the UK or, you know, whatever, and I had the money to go somewhere and try something different, I would. So it's not about knocking it, but it's about thinking about which bit of it works. You know, that's all I would say, because I don't actually know about the specific treatment. But the sort of transcranial stimulation research is still ongoing.
some of the things
It's
are
ongoing.
very good.
Shruti's doing some,
Yeah.
Dr Garg, like I say, is
Yeah.
doing some research, I can't recall, right
Yeah.
at the moment, he's looking at
Yeah.
NF patients, you know,
Intervention
patients,
medication.
looking at it as an intervention and looking at
Yeah.
EEG changes that occur. So
Yeah.
this isn't to sort of poo-poo it, because we know that, you know, there are lots of things that are potentially, you know, we might find to be potentially beneficial. But what you want is the research evidence. But, you know, if they've got a multidisciplinary approach like the one that you're describing, then that will be beneficial. Yeah.
So, yeah.
How competitive are the academic clinical fellowships in Manchester?
We're interviewing soon. I'd say they're fairly competitive, but I suspect they're probably not as competitive as, say, you know, for neurology or whatever. And one of the reasons is because people don't know about them.
Yes.
That's what we've realised is that, you know, people say, oh my God, I didn't know that, you know, this was available. So it's some of it's to do with publicity. Regardless of how easy or difficult it is to get on an ACF course, really it's about maintaining the research that is the challenge. Being able to do achieve your clinical competencies in 75% of the time, because you have to do that. You have to keep up with that and then keep up with your research as well. It's quite a tight timetable.
We have one foundation year training who's at MRI. If you email me, I'll give you his email and you can talk to him. I know you're interested in academic track, and he's the first one we have had in foundation year. Okay, and we have a few in core, and I think.
And we've got Mimi,
Yeah,
one of our STs, high specialist trainees. She's an ACF, and she's had 2 babies while being an
That's
ACF.
terrible.
So but she's done, you know, she's been very organised. She brings her babies to the academic days. Thank you. So I would say, you know, it's probably not as competitive, but one of the reasons is that people don't know. I think the other thing is that the psychiatry generally is undersubscribed, and child psychiatry then as a subspecialty is more so. And what you find is that when specialties are undersubscribed, people erroneously think, you know, it's better to go to London or whatever. And in some way, in some senses it can be, if there's a particular research that you want to do. But what I would say to you is that those opportunities are available here as well. And I think the other thing that Latha, you know, did mention was that the trust, MFT, MRI, have given us money, sessions to one of the consultants, Rachel Alvin, and then one of the other consultants, Dr Theodosi, and the idea is to further develop the CAMS research hub, because there's been a long history of lots of child psychiatry research in Manchester, and you know they want that to continue. And I think it's also, there's a lot in the news about child mental health and mental health in general, but a lot in particular about child mental health and child mental health services, which have been, you know, severely underdeveloped, severely underfunded. So, you know, I think it's a good time to sort of think about a career in, well, I think it's always been a good time, but I think I think there's going to be an expansion in services and a change, because there's been lots of development, research, neuroscience development, which it isn't possible to immediately translate neuroscience information into clinical practice, but that will happen slowly. So the way that I think child psychiatrists now practice is much more medical than it used to be. It used to be much more of a sort of social care, social work model, lots of psychotherapy, whereas our work now is much more like other bits of medicine in terms of assessment and diagnosis and interventions, and according to the evidence base. So there's been quite a shift, Because I think one of the challenges that people find when they move from foundation to doing psychiatry is that it's a very different way of looking at, it's a very different way of practicing clinically. I think that's what they feel, but actually I think it's just because it's not explained to them properly, and I think they can find it a little bit strange and a bit of a challenge. But I think that's much more about how things are explained and you're taught rather than what the reality is.
Okay, anybody else? Yeah.
With the types of presentations that you get, like referrals from
Yeah.
GPs, for example,
Yeah.
like how many would you say you start seeing severe social issues within a child? For example, if they come in with low mood or something, and then you start seeing behind the scenes worse, more severe social issues, and you start uncovering that from the child. Is that a common theme, or is that fairly rare?
What do you mean? Do you mean social care
Yes.
problems? Or?
Social care things regarding parents would mean.
I think we see. I think there's separate things, aren't there? There are things about the way children are cared for and parented versus, where something reaches a safeguarding threshold. So people have lots of different parenting styles, and there can be lots of different expectations within families. If you had a conversation with the person sat next to you about how you were brought up, we will have all been brought up very differently, with different sort of rules, expectations, etc. So we're very mindful of that. But then there's that versus if somebody comes and says to us, oh my mum really smacks me, or my dad did this, or my parents are drunk every night, etc., which is child protection safeguarding. So I mean those sort of disclosures are not uncommon. We have a lot of liaison with social care for lots of different types of safeguarding, whether it's physical abuse or neglect is usually not meeting a child's needs, and that can be for lots of different reasons, like not getting them into school, not bringing them to appointments, not administering their treatments, whether it's medication or whether it's bringing them for therapy. If they look like they're not washed, they're not clean, they're not eating. We see a lot of, I think we see a fair bit of a sort of group of young people where they are being sexually exploited. So we see young teenagers with CSE. So we see a fair bit.
I think it also differs in different departments depending on our catchment area. Okay? We have in Central a very colourful multi-ethnic group, and it's fantastic. I would think that compared to another place, we've got less issues of social issues being a part of our majority of our presentations. Majority of the ones who come to us have got other things wrong with them, which are developmental disorders, something neurodevelopmental disorder. Of course, some of them will have social situations as well. But I think if you worked in another place, there'd be a lot of social. It can differ as well, really.
All our CAMs, we've got 4 CAMs in our trust, our tertiary outpatient CAMs, and all of them have a slightly different population. So North Manchester CAMs tend to see many more naughty children, who've done naughty things, or are involved in, with the criminal justice system, probably more than we do. But I would say that there's a proportion. I think there's a proportion in all the CAMs. It's not the major presenting, sort of problem, but as part of our assessment, that's something that we always consider. It's and it's not all. So it will be part of, whatever we're assessing. We'll discover this in addition. So somebody will be depressed. Like there's a lad that the boy I was talking to you about, he's a real patient, I think, that we admitted last week, where he's, where he's very depressed, but actually there were safeguarding concerns about neglect, and there have been in the past. because he's being left on his own while his parents are working and stuff like that. So he's still depressed. He has a depressive illness, but there are these additional factors, and that's what I was talking about, was the environment and the care that young people are receiving, as well as their intrinsic illness.
Somebody at the back, many times you put your hands up and I'm asking this guy.
Just wondering, how long does it take you to gather up all the different information from all the different agencies?
Okay.
Is that back and forth with your job? Or?
If you do an assessment of a child, you need to do all these things, bits. Okay, you can't just, like if you see an adult in clinic, you just you do the assessment and you do the diagnosis. In children, you see them, it's a snapshot. So you need lots of information, really. It depends on what the condition is and how long does it take. For example, if it's somebody with ASD, like I do most of the children I see out with ASD, it'll take me about 3 months to complete my assessment. Okay, but that's not the only thing I'll do. That's not the only patient I see. Because one is, if you want to go and see a child in school, you can only do it during term time, and they are in school only for 39 weeks of the year, out of 52. And then you have to arrange them between 9:30 and 3 o'clock. So you can see the sort of difficulties we have and the challenges we have, and when parents can come and see you, when they can't come and see you. So all sorts of things. It takes quite a few weeks to get together all this information. If I'm only seeing a small number, I can do it very quickly, but I'm seeing quite a lot. That's sort of
I think the other thing is that I would say that once you are experienced, when you first see a patient in your assessment, you have a pretty good idea of what's going on. That is different from being able to present evidence that supports what you think is going on. So our assessments, our work is all clinical. So there isn't a blood test or an X-ray or an MRI that says this is what they have. So if you go to a medical clinic, I've got a pain in my knee, and they'll do they'll take a bit of a history, or when does it hurt, blah blah blah, and move it about a bit, and then say, all right, we'll get an MRI then, or there's nothing wrong with you, and then they'll tell you what it is, and you have a bit of physio. Okay, so it's job done. But if Latha wants to say this child has got ASD, then she has to present all the evidence that supports that in a report. So you have to be able to justify your diagnosis, and you have to do that in any area of medicine. But for us, it's much more laborious, because one of the reasons that we have to, as Latha said, it's a snapshot. One of the other reasons we have to observe children elsewhere is to establish the pervasiveness of a disorder. Because disorders like ASD and ADHD, they're pervasive. So if you've got ASD, you have it whether you're at the Winnicott Centre seeing us, whether you're at school, whether you're at home. So if those symptoms or behaviours or things that parents are describing disappear in school, well, clearly it's not. It's something else. It's there's something in the environment that's influencing what's happening. So it's about being able to justify your clinical diagnosis. That's the other reason that there are so many steps. If we, say if there was a blood test, then it would be a bit shorter. But the really exciting thing about it is that it means that working in this way, I think it's much more of a sort of thinking and intellectual exercise, and it makes you a really good clinician. Having been a paediatricians, generally, nice people. That's why I was a paediatrician.
That's what you left.
They're generally nice people, and they're quite thoughtful compared to other specialties, and they like to think that they are more thoughtful than others. But one of the really interesting things is that you realise, with all this due respect, the limits in terms of people being able to synthesise clinical information and think about complex problems in other specialties. And that's something that has become more and more evident as I have sort of gone through my training, and then I spend quite a lot of time with paediatricians thinking about their cases. And some of that is just the way medicine works. Medicine works in that this is what you guys are being taught, so carry on doing it, don't start doing anything different. I don't want to get blamed for anything. But somebody comes with these symptoms, you ask them questions about their symptoms, and then you see whether it fits a diagnostic criteria once you've done your examination, and you base your tests on your differentials, and then you say it's this, this or this, and then if it isn't that, well, there's not a lot we can do. And that's how medicine works. But that's not how child psychiatry in particular works, because we are seeing children who are a work in progress. They are developing. They are all at different developmental stages. So sometimes they will present with things up which aren't fully formed illness, but they might be indicative of something later, or they don't reach diagnostic threshold, but they are still impairing and they need intervention. So that's something that's quite different from the way other areas of medicine think. Other areas of medicine are beginning to realise that, you know, that actually they might have to sort of change a little bit and think outside diagnostic criteria.
I realised she did all of the talking and she didn't have that.
So actually we can lip read. Okay, so Latha said that, for me to do, that people want to know a little bit about, or Ellie, you want to just talk a little bit about the Manchester Arena bombing, which was in 2017, wasn't it? As Latha said, I work in Paediatric Liaison, and what that, it's a funny name, I've never quite sort of got to grips with it, but what it really means is that when young people present to A&E and they've taken overdoses or they've self-harmed or somebody thinks they're psychotic, etc., then the general child and adolescent mental health service, general CAMS, where Latha and I both work, you know, we have somebody on duty and they see that patient and we sort them out on the wards. In addition to that, the specialties in the hospital, like nephrology, oncology, etc., as part of their service design and what's thought to be desirable and good practice, will have some psychology time attached. And most of it is psychology, because I only work with Paediatric Liaison 2 days a week at the moment. So they have some mental health input in the diabetic clinic, with cystic fibrosis patients. And you can understand why that would be, you know, because of the burden of chronic illness on the child and young people and the family, etc. The burden of diagnosis, you know, it's kind of self-explanatory. But most of the specialties don't have any mental health time attached. If you are not a doctor and you're an allied professional, you can say things like, well, actually, you know, this isn't my job, so I don't need to do this. But if you're a doctor, you tend to see people who are referred to. So I see any patient that's kind of referred. So I see all the patients that, you know, whether they've got, you know, rheumatology problem or gastro, whatever, and a lot of what we see are things like depression and medically unexplained symptoms. Now, so that's what the paediatric liaison bit is basically seeing children on the paediatric wards or children who are under the care of paediatricians in tertiary care in specialties versus the overdoses and the self-harm patients. So when the Manchester Arena bombing happened, when there's a major incident like that, the major incident protocol in hospitals is put into place. You know, if you look on the intranet of whatever trust you're or wherever you're based, there'll be a major incident protocol. Now, psychiatry wasn't on the major incident protocol. It is now. And however, what they did do was the A&E staff called the child psychiatry ST who was on call, who was Nadia, who's one of our trainees, and she came in, and what they wanted her to do was to speak to family and parents. I don't think they were entirely clear about what they wanted to do, but that's what it turned out to be, and they found a place, a relative's room, and she waited and said that nobody really came until about 4 in the morning, and then parents started to come in, and some parents had come in, and actually their child wasn't in A&E, and other parents with their children were in A&E, and she was able to sort of answer their questions and liaise with them and provide them with some support. And the staff from that night were really grateful and very complimentary about Nadia and her work. She's a fabulous trainee, so whatever she was doing, whether it was psychiatry or not, she would be fabulous anyway. But they realised that actually this was a really necessary and important role to have somebody to speak to the families and relatives. And you can imagine, you know, they hadn't thought about this, because I think when people think about major incidents, they think of sort of pile-ups, or if there is something like a bomb or an explosion, I think the I don't think anybody envisaged that it would involve so many children. So the idea that you needed a child psychiatrist or a child mental health services involved was something that just wasn't on anyone's radar. But they were very pleased and they were very grateful for that intervention because it was really helpful to the staff and to the families. Then the next day was a Tuesday, and so when I came into work, one of the things that we did was to do a sort of, one of our managers and one of the other consultants, the head, our clinical director, did a walk around the wards to see what patients we had, because we had a lot of patients on ITU, we had some patients on the Bones ward, but to look at what was required and what people needed and what we needed to do. Now, as I said, we weren't really involved in it, so we had to make it up. We had to think about what was needed, and what became very clear was that the staff needed a lot of support, particularly the paediatric intensive care staff. That was the thing that came through to us initially, was that a lot of the staff on paediatric intensive care were newly qualified nurses, so band 5s, they're just in their early 20s, and they were really struggling with looking after children who'd been deliberately harmed, children who had multiple traumas and injuries of a nature that you don't see outside of water. So although they were used to seeing road traffic accidents, etc., it's a particular type of injury. You have broken bones, etc., but the sort of things that they were seeing with shrapnel, etc. It was extremely traumatic, and the context of what had happened, that this was a deliberate act, was very upsetting and traumatic. And I think for all of us, I think for people who live in Manchester, and I'm from Manchester, so I'm a Mancunian. There have been lots of incidents elsewhere. There've been the Waterloo Bridge thing. Not that it was quite close in time, but the idea that it happened so close to home, I think, was very upsetting for staff as well. So we provided staff support sessions, time for staff to talk through things. Some of them did it in groups, some of them wanted to talk about things individually, and it's about practical things as well. About when you're on a ward, it's slightly different because you can come and go. But when you're in intensive care, the parents are there, and you're doing one-to-one nursing or two-to-one nursing. What do you say to parents? What conversations do you have? So that was the initial staff support, was just the day-to-day. The other bit of our work was to spend time and speak to parents about what was happening. And some of those conversations were really about sort of just listening to them, about how things had happened. Some people had accompanied their children, and some people hadn't been there. They'd been with the other parent, or they'd been with friends. Some people had taken a long time. For example, there was a young person that we had in ITU, and the parents, were coming from somewhere very remote. So it took them sort of 40 hours to kind of get here. So spending time talking to them about what was happening, translating, and helping them digest some of the information that they were getting from the surgeons and the intensivists and etc., because it was a lot of information, but also to talk about their families and their children, because that's what they wanted to do, was for us as a team of professionals to understand what their children were like. That this is that people because we didn't know what they looked like. They didn't look like they did when they were well. But to be able to see photographs, to talk about the sort of things that they like, their hobbies, etc. And for us to, and what I found myself doing was actually getting a sense of what families were like. Because some families were intact, some families were reconstituted families, some families there was lots of conflict. People were separated, they didn't speak to each other, etc., etc. So all of those things that we see in our work all the time was we were seeing in this situation as well. So there were, you know, parents who had no contact, were divorced, had new partners, had other kids. You know, there were all sorts of family difficulties in terms of dynamics that, you know, that became very, very apparent very quickly, and it was about helping to manage some of those things and helping people talk through. So parents had different opinions about what they wanted in terms of treatment. And then with a couple of the parents, we had conversations about what they wanted in terms of whether they wanted care to continue, you know, because that was something that was brought up with, you know, by the intensive care consultants, and it was helping parents go through that process of thinking about what they wanted, you know, whether they wanted care withdrawn, the sort of developing the understanding and then the acceptance that their child was never going to be the child that they were before they went to that concert, before this happened, that they were going to have a permanently disabled, dependent child. So as time went on, those were the conversations that you know, we were having with the parents. And then as the children and young people got better and, you know, were no longer ventilated, etc., and then the work started with some of the young people to talk about some of the things that were happening, and also for them to understand what, some of them wanted to know what had happened, some of them didn't want to know what had happened, they didn't want to know the details, but some of them eventually, you know, wanted to ask questions or find out in their own time, etc. But it was again talking to them about how things had changed for them, and also about accepting treatment and some of the changes. For example, we had a young person who had to have you know, surgery which was, you know, going to affect their hands, and they were somebody who was a very keen artist. So having to talk through the sort of grieving process about losing some ability in their hands, scarring, etc. So a lot of that work was about, you know, helping young people just talk through those things, because sort of acceptance, etc., and moving on is a long way forward. But one of the things that we needed to do was facilitate treatment, because one of the best things about children and young people is that in any circumstance they're still children and young people, and, you know, they can be stroppy and difficult, and no matter how much you say, yes, you need to have this, they don't want to, etc. So, you know, and if you're in pain and something horrible's happened, then it's very difficult. One of the other things that we had to do was to talk to young people who'd gone with friends, and their friend had died, and they'd survived, and to, you know, be with families when they broke that news, and that was extremely, you know, difficult for families. But, you know, supporting them to be able to do that and think about the right time, although I suppose the better time to break that news. And then ongoing staff support. The sort of things that we learnt from this was, one, that you know, the staff were fabulous. People did lots of extra time. One of the things about working with the NHS is that you always do lots of extra. That's a given. But, you know, people were fabulous, and lots of people who were extremely junior and scared and anxious and upset, you know, did fabulous work. Everybody pulled together. The families were all great. The thing that really stood out about the families was the lack of anger. People were upset, but they were incredibly calm. You know, one of the parents said to me, that, you know, they didn't feel angry, and that they were mindful about sort of things that were in the media about, you know, the ethnicity or the religion of the bomber, and, you know, and I thought it was a very brave thing, and said to me, you know, I don't know if you're, you know, Muslim or whatever, but lots of the doctors I can see they're either Arab or they're Indian or they're Pakistani or something, and a lot of the staff are, but we're not angry, and we don't think like, which was incredibly kind and brave thing to say. I found that the staff were much more angry, and I think some of that was, I think, because they understood the sequelae to what was, what were the initial injuries, because you find people are really pleased because their child or their loved one has survived, but when you know what some of the disability is going to be, it's very difficult, and also when you're not emotionally attached to somebody, then you can be intellectually more angry about what's happened. There was a lot of support generally from funding and the government and etc. And they set up a hub to sort of help people to make sure they got the right care. When we then had some months later, we looked back at what had happened and our response and what we've done. And one of the things that became evident was that there were lots of staff groups that had been missed out, because this wasn't a coordinated response. This was just something that we did because it was needed. But like people like porters and radiologists, there was a radiologist who came to a meeting and said, he said, because they did all the scans and the X-rays and it was horrific for them. They did a lot of the intervention radiology and it was terrible. The porters who, were talking to the parents and taking patients from here and there, etc. The cleaning stuff. So basically everybody, the junior doctors who were all on different shifts, so it was really difficult to capture them. So it made the hospital think about staff support in general and about how they can better do that, not just in response to a major incident, but also when, in everyday life, because there are lots of chronic stresses, working in any organisation, but particularly in healthcare, because it's very demanding. The other thing was the response, excuse me, of other patients who, was that there were other patients who had been injured in road traffic accidents or something else, and were equally, were going to be equally disabled or were, and yet this group of patients they saw as getting preferential treatment, and they found that really difficult. Some parents, expressed that they weren't taking anything away. This was a horrific thing, but in the end, as a healthcare service, everyone should have access to the same things. So there was sort of fast tracking of the patients for physiotherapy and other things which other patients just didn't have access to, which was interesting. And I think it's very normal, because I've noticed that before, is that families are interested in their family, whereas we as professionals are interested, we look at the ward and the needs of all the patients on your ward or in your department, whereas families focus on their, their child or their, loved one, whoever it is. And some of the staff felt a little bit of that as well, was that not that they would grudge that, but they wanted that kind of gold standard care for all their patients. One of the reasons that this resilience hub was set up was not so much to provide therapy or intervention, it was much more to make sure that this group of patients got access to services locally, which are quite scarce. And what we're seeing now are the sort of sequelae. So most of our patients were transferred, because they were from all over, were transferred back locally once they were well enough for follow-up. Some of them are, local to Greater Manchester, and have, one in particular who has traumatic brain injury, quite severe, and is requiring follow-up and intervention now. So some of the work, for us is still ongoing. Okay. So now we are on the major incident protocol. So we are called, and they are looking to, they're putting in a bid to expand the service, so that we're not just for this reason, but so that we are able to cover more of the hospital, or all of the children's hospital, rather than just the specialties that have some psychology time attached. Okay. So I think that's it. Yeah. Any questions?
So I just have a question. Did you train in child and adolescent psychiatry, or did you train in liaison psychiatry?
No, I did. Well, I did a lot of paediatrics. So I, did all my exams. I had a year left before my CCT, so I was nearly a consultant, so I only had a year left. And then So I had to go right back to the beginning and just do normal psychiatry training. And then, because you don't have to have done paediatrics to do liaison psychiatry, but it's really helpful because I know so much about paediatrics and how things work and how people think. It means that I can take real shortcuts in communicating with the paediatricians. A lot of this is about understanding what your colleagues are doing and how they're thinking and how they're approaching a problem versus how you approach a problem. So it wasn't liaison psychiatry. Liaison psychiatry is just a part of child psychiatry. But my paediatric background kind of informed that interest, I would say. But I would say that the advantage that I have over other people is being a doctor. You know, being a doctor anyway is an advantage because you understand how medicine works and how thinking in medicine, you know, how that works. Whereas if you're a psychologist, etc., they don't quite get how, you know, medical thinking, you know, the sort of lines that we go along, because their clinical frameworks are completely different from ours. What you spend 5 years or 6 years at medical school doing is you learn how to do assessments. That is essentially what you're learning, is that when you look at it, that is what all your placements are based around, is taking histories, doing examinations, learning about investigations. So by the time you qualify, and definitely by the time you get to be a consultant, what you're really, really good is weighing up information and synthesizing information and coming to conclusions, like Latha said. So it's a really good skill. So just being a doctor really helps. But having done paediatrics really, really helps because, say in this instance, you know, my psychology colleagues, obviously I couldn't see all the patients, saw some of them, but what they struggled with was and they do in other specialties, is they struggle with the medical information. Is that if you've never had a conversation about withdrawing life, or you know life and sustaining care, or you've never had a conversation with somebody about you know, their child being permanently disabled, then it's very difficult for you to talk to someone about it in a meaningful way, because people will come to you regardless of, you know, whether you're doing, you know, whether it's in this situation or whether we're in clinic. They'll say, oh, the GP said this, or the neurologist said that, or something, and you know very well they didn't, but you know that from experience. So that's what I would say, is that paediatrics is helpful in that sense, but it's not essential, because, you know, as a doctor you would have done some anyway. Yeah.
This question goes to both of you. I'm not sure if you know the answer, but would you say it's easier to treat children with psychiatric problems than adults because of like the nature like of their age and like their mind being more easy, like sort of influences of like changing their physical. Sorry, I'll stop my question. But yeah.
Yeah. Well, I think it depends on what you mean by psychiatric problems, because, you know, if you're talking about major mental illness, then actually the younger you end up with major mental illness, then probably the poorer the prognosis. Because if you end up with a major depressive illness, say when you're 12 or 13, and we've seen this, and it hugely affects your development and is really impairing. You know, if you're talking about severe illness. So yes, it gives you the opportunity to intervene early. You know, that's the basis of all the early intervention services. But the jury's still out about how much good they do. But if you end up with something really unpleasant, a really severe illness, then, you know, you can imagine the earlier you have it, you know, the outcomes are not likely to be as good. So if you look at major mental illness in women, like say you look at schizophrenia, the onset is later in women, and they tend to do better. And one of the reasons is that they are functionally sort of a bit further along than young men are. So if you lose a bit of that, you're still a bit further along functionally, and that's thinking about, you know, things like that. So it really depends on what you're talking about. But if you're talking about things like neurodevelopmental disorders and being able to provide intervention early, or other emotional difficulties where you're providing intervention early and therefore you're preventing something becoming more sustained and severe, then yes, you're able to, you know, that, and I think that's one of the things that's really positive, isn't it? It's really nice, you know. it's really, it is quite heartwarming when you make a difference to somebody because they're, you know, they can do their work better in class. You know, that's what they'll tell you. I got a certificate, you know, rather than getting into trouble every day, or they can do their reading better, or, you know, they're not falling out with their friends so much, etc. You know, because they're getting the support that they need, or their parents are able to, you know, take them out and manage better in public. So, yeah, I think there's probably a lot more positivity in child psychiatry than adult. And one of the reasons is that adult psychiatry services have been so pared down that they are just not funded to focus on anything other than major mental illness and risk. You know, and they're absolutely stretched to breaking point. Yeah.
Excuse me. Referring back to the wards,
Mm-hmm.
so these children have got comorbidities. Was it hard to engage them in such therapies, or was it a different approach? Or how did you go about going onto the ward? Is the question really.
So what you mean, if we're in paediatric liaison, if we're referred somebody who's...
So after the Manchester bombings,
Right.
let's say for example, the child's just come off ventilation, they're a bit drowsy, etc. And their parents are there, is it hard to engage all the groups together, or is there a different approach, each different comorbidity?
No, not particularly. I mean, I think what was tricky was managing some of the family dynamics, you know, where people were already very angry with each other. So, you know, that was probably more difficult than anything else. Because otherwise, if you take the context away, you know, these were just very injured young people, you know, and we provide a service to like the burns unit, etc. So we see young people like that anyway, but the context is slightly different in that, you know, obviously that this was something that was done intentionally to harm them. So no, I wouldn't say it was any more difficult or any easier. What I would say to you is that in clinical medicine, it's often the things that you dread that are a bit more straightforward versus the unexpected. So when you expect something to go really smoothly, but it surprises you and sometimes doesn't. So, and the young people that we saw were, you know, without exception, were really quite amazing. You know, they were all incredibly, I don't know, I think, not angry, you know, they were, some of them were frightened, some of them were sad, but I think the hardest thing with a couple of young people who'd lost friends, you know, that was incredibly difficult, I would say. And breaking that news was difficult, well, it was obviously more difficult for the parents, but it was easier for us to help them do it.
So we can wrap up there. Just a massive thank you to you two for
You're
coming
welcome.
along. And thank you very much.
Thank you. We're just very impressed that so many people are at home watching TV.
Thank you very much. Rock my head.